Welcome to this Medscape Live event. Once this program begins, you will have access to several interactive features designed to enhance your educational experience. These include viewing the presentation slides, reviewing the agenda, and participating in live polling throughout the session. During the presentation, you can take notes if you are using the Medscape Live app. Your notes will remain available in the app after the event for future reference. Questions may be submitted to the faculty at any time, and selected questions will be addressed with responses provided during the Q&A portion of the program. At the conclusion of the event, educational credit can be claimed by clicking the Earn Credit link on the side panel or scanning the QR code. Presentation slides will be available for download immediately after the session using the Medscape Live app or by logging into your account at medscapelive.com. While you're on the Medscape Live app, you can explore and register for upcoming events. Thank you again for joining us. Our program will begin shortly.
Yeah, they're live streaming. Excellent. Good evening, everyone. Welcome to tonight's program. We're very excited to have you here, and a special welcome to all of our virtual attendees who are watching via the Medscape Concept, a Connect platform. We invite everyone to join the Medscape Live Connect platform by scanning the QR code on the front of the agenda at your seat. Joining this platform is a way to ask questions, to follow along with the slides, and also to participate in the polling questions we have for you this evening. We encourage the virtual attendants to ask questions and participate in the polling as well. So tonight's program, From Treatment Advances to Individualized Care in Hemophilia. We are fortunate to be supported tonight by an independent educational grant from Sanofi. And so here's the use your own technology. So the interactive experience during this live event can be accessed by scanning this code, and you can do all of the things I previously mentioned. If you have not connected to Wi-Fi, you can use the Medscape Wi-Fi connection, and you see the password there. All right, so I am your moderator, Stacy Croto. I'm a pediatric hematologist at Boston Children's Hospital and the medical director of the Boston Bleeding Disorder Center. And I'm joined by my two esteemed panelists. To my immediate left, Dr. Miguel Escobar, who's professor of medicine and pediatrics at McGovern Medical School and the director of the Gulf States Hemophilia and Thrombosis Center. And also Ms. Jennifer Maas, who is the chief nursing officer of Innovative Hematology in Indiana. So a brief overview of what we have in store for you tonight. So I will present first, talking a little bit more about beyond ABR, getting above and beyond just thinking about bleed rates in the treatment of hemophilia. And then Dr. Escobar will take over from there, talking a bit more about matching treatment to life and individualizing therapy selections and counseling patients through that change. And then Ms. Maas will talk about making it real in your hemophilia treatment center, the important interprofessional team-based implementation strategies and techniques and action planning that is needed for these changes. And then we'll all come together and do a little bit of a what would you do. We've all put together a few cases so that we can apply the evidence together, thinking about individualization of hemophilia care. And then we'll give you a few takeaways and open it up to question and answer. So at any point over the course of the presentations, if you have questions, do please use the Connect platform to enter them, and they will collate all of them, and we'll be able to address them at the end. So to kick things off, of course, we have an open polling question for you all. So in your clinical role, which single measure of hemophilia treatment success do you rely on the most? Annualized bleed rate, factor levels in inhibitor assays, PK profiling, clinical joint health assessments, musculoskeletal imaging, physical functioning self-assessments, or psychosocial and quality of life self-assessments. You always hear a terrible echo. It's a little bit. Excellent. Just as we had sort of predicted and hoped, a nice mix, I'm guessing, of different provider types and different roles that individuals are coming to tonight's conference with, really well reflected in the different measures that people sort of prioritize most within their roles. So thank you so much. All right, so beyond ABR, of course, as we're treating hemophilia, as we're treating bleeding disorders, preventing bleeding is the most important thing. But once we have achieved bleed prevention, where do we go from there? And how do we think about important metrics to help distinguish the relevance, the importance, and the ability to individualize treatments at our disposal? So hopefully this model will be familiar to you. This was generated by Mark Skinner and many of his colleagues several years ago now. It's a little bit of a visual recreation of their initial visualization of how do we think about the milestones that we need to achieve towards health equity, thinking about patient-relevant outcomes, as well as milestones getting towards normal hemostasis, thinking about functional cure. And I often, as I'm looking at this tool, think about this with a few different hats on. So one, when I'm thinking about my patients in the United States, and this would be true for other resource-rich countries, you can actually sort of map progression up these stairs, if you will, with access to new and different treatments. So as we first got our lyophilized concentrates, very much focused on just preventing premature death and improving survival. But as we've had easier access and more types of treatments, we've been able to march up in terms of success. And we're going to talk a little bit about the generations of hemophilia patients and how that might overlay the steps that we make, but we have been making progress. The other way, though, I think about this is just a general provider with my global hat on, in a way of thinking about the disparities in access and care across the globe. So even knowing that we have the therapies available to help us march up this staircase, depending on where you live in the globe, you may very much still be sitting on that dark blue first step. So I mentioned the generational changes in bleeding disorder outcomes. And it's actually really important to think about our generations of hemophilia individuals as we think about their baseline status, their baseline physiology going into treatment changes in prophylaxis, and how that may change or limit their success marching up those stairs towards the ultimate goal of a bleed-free mind. And so these data to the left were called almost a decade ago now from the CDC data. That was a combination effort, of course, across the CDC and our Hemophilia Treatment Center network, where they looked at 4 different birth cohorts and looked at bleed rates, availability of prophylaxis, utilization of prophylaxis, and musculoskeletal health. And perhaps not surprisingly, as you look at the older born before 1958 cohort, at that snapshot, 16% were on prophylaxis. Nearly 70% had activity limitation. And not surprisingly, as we moved up to more recent cohorts, here, the youngest born in 82 to 93, 45% on prophylaxis with a 15% limitation. So we know that prophylaxis is important. We know that access to prophylaxis is important. And as our recommendations for even standard half-life factor concentrate became more uniform and more consistent, we see improvement in the rates of prophylaxis, of course, and also reduction in physical function limitations. But that wasn't the end story, that we didn't fully achieve the goal, because as you can see, the figure to the right looks at the joint outcome study continuation. So many of you will be familiar with the joint outcome study that was published in 1997 that demonstrated the importance of prophylaxis and importantly, demonstrated the importance of early initiation of prophylaxis. So starting regular prophylaxis before 30 months. Imagine that in today's world, starting prophylaxis just before 30 months compared to using on-demand up to 6 years. We saw marked improvement in joint bleed rates and imaging of the joints by MRI. Doing their very best to continue prophylaxis up until the age of 18, When we looked at their MRIs again, we still see that even in those patients who started prophylaxis early and made their best attempt at factor prophylaxis by age 18, only 65% of them had pure clean joints by MRI. So even with our best attempts, we're seeing potentially early evidence of joint changes, joint damage. So what can we do to help prevent that from progressing? So we've achieved this new golden era of hemophilia treatments. These figures sort of represent different categories of treatments that we now have available for prophylaxis and the impact of those categories of treatment on hemostasis. So you'll recognize the rapid sawtooth as our standard half-life products. As we've been able to engineer them and extend the circulating half-life, we have similar peaks and troughs, but the infusion frequency was able to be spaced out. But then we had additional innovation. We have the non-factor therapies. So you no longer see that up and down sawtooth pattern of protection. You see a nice consistent level of protection of hemostasis, but you'll note it's not in the normal range. It sits somewhere in the mild hemophilia range. And then we had the addition of gene therapies. And overall, the effect of the prior gene therapy that was licensed for hemophilia A was a bit waning over time. It does seem to be a bit more stable for our current licensed hemophilia B gene therapy. But the point is that we have a number of different categories with different proposed opportunities for improvement in hemostasis, administration, frequency, and administration route that we can start to use to marry with the various cohorts and generations of hemophilia patients with the different goals that individuals with hemophilia have to try to optimize the best prophylaxis for them in the moment. So what are some of these key outcome assessments in hemophilia that could help us understand how well are we doing with the prophylactic agent that we have for any given patient? So one important category, of course, is bleed prevention and control. Looking at that breakthrough bleed rate, their ABR, if you will. Are they bleeding on this regimen? Looking for inhibitor development, which is, of course, unique to the use of exogenous factor 8 or 9. And then I actually kind of think about trough factor levels, PK profiling, and thrombin generation assays sort of together in that they help tell us something about the degree of hemostasis that we're achieving. So certainly when we're leveraging factor concentrates and we can measure 8 levels, are we looking at just the minimum that patients are getting to? Are we thinking about the profile and really more of like an area under the curve? How well overall are they achieving better levels? Or especially with the non-factor therapies, do we not have a specific factor level that we can measure? Are we leveraging something like a thrombin generation assay, some other metric to give us a glimpse at how the hemostasis is for that individual? Of course, the challenge with those assays being that they continue to not be readily available in most clinical spaces and are not fully standardized. We can also look at outcome assessments, joint health, subclinical joint bleeding. So whether this is the traditional HJHS, whether this is other joint imaging, ultrasound, MRI, can all be helpful. Certainly, I think in all, at least most all of the HTCs, we have some type of clinical joint assessment like the HJHS, but of course the resolution there in the healthiest joints is quite low. And so you will miss things on just a clinical exam that you will be able to pick up potentially by ultrasound and certainly also by MRI. And then third, and importantly, we have treatment and disease burden, psychosocial considerations, quality life assessments, and those can help us dig into, from a patient perspective, the sense of treatment burden, disease burden, daily activity limitations, et cetera. So I have put a snapshot here of some of the phase 3 ABR data from some of the novel therapies. And I highlight this for a number of reasons. I think I've captured many of the more recently licensed non-factor therapies and one of the recently licensed factor 8 therapies, because I think it's important to remember that these are not directly comparable. So of course, for all of these agents, it's very important that they show at a minimum no worse in bleeding compared to their comparator group. Hopefully they show a reduction, but across each of these, how bleeds are captured, what the bleed definitions are, whether or not bleeds that are reported are adjudicated by providers, how they are analyzing and calculating ABR rates, how they're choosing to represent the ABR rates, whether it's all treated bleeds, all bleeds, spontaneous treated bleeds, varies a lot actually from clinical program to clinical program. So you have to be very cautious, even when we're thinking just about ABR, when you're reviewing the data for these different agents, especially if you have, as we all do, any tendency to try to make comparisons in your mind, because unless you're very clear on the patient population that was recruited for the trial and exactly the way the bleed data has been reported, it can be really easy to make errors in one's thinking in terms of comparisons. We also have a number of patient-reported outcome measures, so PROs, and I've listed just a few of them here. Many clinical trial programs will use multiple PROs because, as you can see, some focus a bit more on psychosocial and quality of life functioning. Some focus more on disease burden with different domains or treatment burden. And so by using multiple, you can get an overlap of certain domains that may be helpful. We do, though, have to be cautious of overburdening patients, overburdening clinical trial participants with too many surveys. And so to the extent that clinical trial programs do leverage some of the same measures, that can be helpful. Similar to the ABR data, I show some of the PRO data from just a limited number of recently licensed novel therapies. As you can see here, many of the quality of life metrics are deficiency scores. So how much is this negatively impacting your life, which means that low scores are good and high scores are bad. So you'll see in many cases, as is the case here, it's reported in the negative, where it seems like, well, the bar is much bigger for patients on the novel treatment, but having a more negative number is actually a positive thing. And I think one of the things that can often be surprising is that the delta between the novel treatment and the baseline is often not even as big as one might predict, given the reduction of bleeding, the different mode of administration, the different frequency of administration. But I think some of the challenge with individual patient-reported outcomes, person-reported outcomes, is we all normalize our day-to-day lives. We get used to what we're doing and can make an assessment on, how negatively different things impact us. And then once you go ahead and make a change, sometimes you then appreciate how burdened you were before. And so sometimes these metrics don't always fully capture the net improvement that individuals ultimately report. We can also leverage these metrics, though, in day-to-day clinical practice. And so this was an example of a group who basically used an online platform to distribute patient-reported outcomes to individuals that decided to participate across the US with hemophilia of different severities. This is the PROMIS quality of life outcome measure. And from the people that reported, they were able to also get permissions to review some medical records. And so we know of the patients that chose to fill out these quality of life questionnaires, whether they happen to use factor VIII concentrate, whether they happen to use non-factor products. And so you can get a sense of how they scored physical functioning, social roles, fatigue, et cetera, and differences and similarities across severe disease, moderate disease, mild disease, using different types of categories. So this is a way one could, at their own HTC, decide to take a snapshot of how your patient population is doing with different types of therapies, or opportunities for us as a global HTC network to take a snapshot of kind of quote-unquote real-world glimpse of how our patients are doing on different categories of therapies. And this is a similar presentation of data, but this is using the HemoTem. So thinking about treatment burden amongst patients with hemophilia, and again, discriminating between those that reported using factor VIII concentrate between non-factor concentrates, for example. So I would say one of the important things is really thinking about individualizing management. And there's a number of considerations, and each of these represents various domains of things that are important to think about: hemophilia-related variables, patient-related variables, treatment-related variables, and environment-related variables, and the degree to which those apply to any given patient or how they weight them in the decision-making may be different. I think this is sort of a helpful acronym to think about shared decision-making in a decision-making model. And I think it's really important for us to remember that shared decision-making is different than an agreed-upon decision. So when I come home, if my husband says to me, you know, I grabbed the grocery flyer, it came in the mail today, and I looked through all the specials, and I went to the grocery store and took a jaunt around and saw what looked good and what was on sale. And I bought this nice piece of fish and some broccoli, so we're going to have fish and broccoli for dinner. And I say, thank you very much. And we sit down to dinner. We've agreed on that decision. We're happy to have dinner. But that wasn't shared decision making. I didn't participate at any stage in coming to that decision, but I went along with this decision because it looked delicious and I was hungry, right? So it's important to remember that when we're thinking about shared decision making, we need to encourage, if it's not already present, patient participation in thinking about what's important to them, what their desire and their goals are. And onus is on us as providers, as a HTC team, to help patients explore and compare treatment options, to help them assess their own values and preferences, and then to reach a decision together. So weighing the data, weighing the information, and coming to a decision together, and then helping them over time evaluate, well, how did this decision impact? Are we achieving your values? Are we achieving your preferences? Are we still not bleeding, for example? And really, as I said at the top of the stairs, right, the real goal is a hemophilia-free mind. And so this is a depiction that Cedric Hammonds and Evelyn Crum and their team sort of helped to put together to visualize, you know, going from different types of categories, perhaps, whether it's the older standard half-life factor 8 and 9 concentrates with, you know, that sawtooth up and down in protection, the regular IV access, you know, worrying about bloodborne infections or injection schedules and joint pains, to as we've modified some of the treatments and reduced the frequency or perhaps the administration, perhaps reduced some of that up and down and provided more consistent hemostasis. It doesn't get rid of many of those concerns, but the intensity or the frequency with which individuals may be considering them reduces a bit. And then something like a gene therapy, a gene editing, modifying early on the disease phenotype to hopefully avoid the need for regular injections, administration, infusions, may help further lighten that load. So we've come back to our staircase here. And as a pediatrician, right, I take care of our youngest patients. I feel like we're solidly sitting on step orange, if you will. So a more unrestricted lifestyle, ability to sustain minor trauma. Many of my patients are regularly participating in all kinds of sports and different activities. But as we think of some of our older generations, older individuals, they may not quite get to that step, right? They're still focused on, you know, having some difficulty perhaps in participation or work. They're still focused on not being able to achieve full mobility and things like this. So I do think that we're creeping up the steps, but where you are may depend on your hemophilia generation, if you will. So the reduced administration for prophylaxis burden, I think, has helped. The improved baseline for hemostasis and the consistency of bleed prevention has really helped. But increasingly, self-assessment of quality of life metrics, shared decision-making becomes increasingly important to be sure we're still marching up those steps and achieving patient needs. And so with that, I will turn it over to Miguel to talk a little bit more about the shared decision-making and matching treatment to life.
Thank you, Dr. Courteau. I think, you know, have you seen Dr. Courteau made an excellent overview of the treatment over time for patients with hemophilia over the last 50 years. And she touched on some very important aspects. Some of them were, you know, how to assess our patients in terms of the bleeding rate and, you know, looking at their psychosocial issues and using tools to help us in the clinic assess those bleeds, you know. So it's important that we talk about, you know, every patient is different, so individualizing treatment is critical in this condition. Because the way we treat patients today is very different from the way we treated them even 10 years or 20 years ago. Completely different. Now, you know, we take one patient at a time and assess, you know, all the different variables that were discussed, and then we can make a decision between the patient, the family, and the team, what is the best option for that individual. Either, looking at their goal or his goals or her goals, and then, giving the options, to try to prevent the most number of bleeds possible. Because my goal as a treater is to have 0 bleeds, but the patient's goals might be different. So I think that's when that shared decision-making comes in. And it's important to be able to provide all the options to your patients. And that's what we do in our hemophilia treatment centers. So, certainly, expanding those options for bleeding prophylaxis. That's our main goal. We talked about certainly the standard half-life factors we've known for years, and either recombinant or plasma-derived, and then we got the extended half-life, and then we have nowadays the high sustained activity factors. And here you see, when those products have been approved. The most recent one is the high sustained, that was approved in 2022 for hemophilia A. For hemophilia B, we've had extended half-life products now for a while. And certainly, in the last years, we've had approval of gene therapy, which has made a big difference, I think, for some patients, especially for hemophilia B. But we got different technologies as well, in vivo gene therapies, gene editing, and cellular therapy. So hopefully, with one of those technologies, we might be able to get close to the cure for patients. Now, Dr. Courteau definitely talked about the hemophilia A trials in gene therapy, right? And we unfortunately saw that the levels were decreasing, and a lot of those individuals that have received the gene therapy for hemophilia A are back to prophylaxis intravenously or using maybe a different product just because their levels are not high enough to prevent bleeds. But certainly we have not seen the same with hemophilia B. We only have one product right now in the market, at least in the US, that has worked quite well for many patients. And I think there are other countries that are working on gene therapy for hemophilia A and B as well, and other trials that are right now ongoing. Okay, these 2 products they were in the market, but they have been taken out for hemophilia A. In terms of the non-factor replacement therapies, so we have the factor mimetics, or substitution therapies, and then we got the rebalancing agents like martezumab and concizumab. And many of you are very familiar with this product, the emicizumab, that was approved in 2017 in the US and some other in the European Union and Canada, I believe so. These are products that most of them are helpful for hemophilia. Emicizumab for hemophilia A with and without inhibitors. And the other non-replacement therapies could be for A or B with and without inhibitors. Now here is the factors 8A mimetic for hemophilia A. So we know that emicizumab, what it does, it binds factor 10A to factor 10, and it mimics what factor 8 usually does in the coagulation cascade. So it helps form that clot, right? It helps thrombin generation. It's a monoclonal antibody that is given subcutaneously. It can be given once a week, every 2 weeks, or every 4 weeks. But there has to be a loading dose, usually for a month, and then they go to maintenance therapy with emicizumab. Again, this is only for factor 8 deficiency. And we have to take into consideration the data that came from the clinical trials. There was risk for thrombotic microangiopathy or thrombosis, especially in those patients that get treated with activated prothrombin complex concentrate when they have a bleed, and these are usually patients that have inhibitors. But, once that was found, that these patients were having thrombotic events, They were not using the APCC anymore, and there were no more thrombotic events. And right now, it's a drug that is being used all over the world for prevention. Now, in terms of the rebalancing therapies, then we got concizumab, martizumab, and fitusiran. And these are all recently approved, at least in the US and the European Union. These are all sub-Q treatments as well. Concizumab and martizumab are inhibitors of the tissue factor pathway inhibitor. So it inhibits one of the inhibitors of coagulation, and that puts a balance in the coagulation system. So what it does, it restores the generation of thrombin, which is what we want. We want to form a stable clot. And by doing this, it achieves that goal by blocking that inhibitor. Now, both, again, are given subcutaneously. What is the approval for concizumab? Is for patients greater than 12 years old with hemophilia A or B, with and without inhibitors. But it's given subcutaneously as well, and it's given daily, just because the half-life is shorter. Now, martezumab is for patients greater than 6 years old with hemophilia A or B, with and without inhibitors. It's also given a loading dose, and then they go to a maintenance dose, which can be done. We do it nowadays in our patients weekly dosing, sub-Q. And then we got the fitusiran, which is a small messenger RNA targeting antithrombin level. So it acts in the liver by blocking the synthesis of antithrombin, again, blocking one of the inhibitors of the coagulation. And that puts a balance in the system. And those patients, start generating thrombin and decreases the amount of bleeding in these individuals. Again, this is all for prophylaxis, not for active treatment. And the treatment with this is, again, subcutaneously, but it's given every 2 months because it has a very long half-life. The only thing we have to do with this is monitor antithrombin levels to make sure they're not too low, because there were some patients in the clinical trial that had thrombotic events, and that was when they were, they had a target of having a much lower antithrombin baseline level. Once they, did the changes in the trial, no further patients develop thrombosis once they keep levels of about 15%, at least, of antithrombin. Now, comparing options here, we have, again, depending on what the type of treatment the patient really would like, we have the different frequencies of prophylaxis administration. We have, for example, concizumab is the daily. We got the standard half-life factors, which are 2 or 4 times a week, depending. And then we got the extended half-life, which is 1 to 3 times per week. And martizumab is usually 1 to 4 times per month, so once a week. And fitusiran, it can be 6 times per year, since it's every 2 months. Time needed to prophylaxis administration, usually all factor replacement therapies, start working very quickly, 20 to 30 minutes. And the non-factor replacement therapies, within 5 minutes. Venous access, again, with these new therapies, is not necessary unless they have a bleed, then you need to definitely administer factor. Either a bypassing agent if it has an inhibitor, or factor 8 or factor 9 if they have hemophilia A or B, if they have an active bleed or they're going to surgery. But these drugs are exclusively for prophylaxis. Now we can see that, and Stacy showed very clearly that the bleeding rate is very low in all these trials, which is great. We have decreased the amount of bleeds substantially with all these drugs. The bleeding rate is close to, some of them even 0. And that is a big difference from what we used to see when we were using just standard half-life factor. And you see here with all the products, the annualized bleeding rate it looks like even less than 2 in most of them, which is excellent, right? Now, the thing is, despite all this prophylaxis, our patients are still bleeding. So if we look at this analysis that was done on 139 patients with severe hemophilia A who received regular factor VIII prophylaxis, you saw the proportion of patients that were bleeding was pretty high, 65%, with a mean annualized bleeding rate of 5. And most of those were joint bleeds, and about half of them were spontaneous joint bleeds. So that's still pretty high, despite doing prophylaxis. And remember, when you're in a clinical trial, usually the prophylaxis is pretty strict, and most patients are pretty adherent to the regimen. So still pretty high bleeding rate, at least in my perspective. Now, we have always had the question, with these new drugs, how do you compare that to a level of factor? Because we're always used to measuring factor level 8 or factor 9. And then we say, if we use a product subcutaneously and it's not replacing it, how close can we get? And the data, we don't have a lot of data, unfortunately. Most of the data come from preclinical studies or just from in vitro data. And it might be an approximation. When we use emicizumab, at least the data shows that maybe it could be close to maybe 15 or 20% of factor 8. But you see here with the other non-replacement therapies, it could be, again, similar, maybe in 10 and the 15% range. Certainly with gene therapy, we can measure levels, which is very helpful, right, for factor 9 at least right now. But with 8, we can still measure levels as well. So the intensity of activity, it all depends, it's something that we have to assess in our patients to see what is the best option for them. It's not the same as having somebody that is maybe 80 years old and stays mostly at home or works from home than having a 21-year-old or a 17-year-old that wants to do sports or competitive sports. That, I think, is something that we have to take in consideration and make that decision, with the patient or the family, what will be the best choice for that individual to maintain, with minimal bleeding or no bleeding. And here, again, we have the different agents and the mechanism and, for what ages it's been approved and in what diseases you can use it with or without inhibitors. And this has made a big, big difference in our population. I want you to concentrate on the factor replacement and the gene therapy, because I think those have made, again, big differences in the way we treat our patients. Nowadays with the gene therapy, we're pretty much close to the, I would say, ideal level of factor 8 of at least factor 9, the data that we have so far, right? Where patients maybe have that, free mind of hemophilia, so that they will not be worrying about all the time, am I going to bleed if I go walking or I'm going to trip or something like that. Most individuals are doing quite well and are off prophylaxis that have received gene therapy for hemophilia B. And the good thing is a single dose that is given about over 2 hours, and that is enough for them to start then producing or excreting factor 9 from their liver cells. But it's a single injection, one time. I'm going to pass it on to Jennifer.
Okay, I got it. Thank you.
You have one too.
Okay, so I was sitting here and I thought, I have a little comparison. I mean, those of us, we all, I'm assuming, came from somewhere. We knew we had our ticket. So just like our treatment products, we knew what we needed to do to get there. We had our destination or our goals of what we wanted to do to get there. But unless we have a team that flies that plane, whether it's the person that fuels it or the maintenance person or the flight attendant, the pilot, all of those people really working together, makes the trip happen and the outcome happen that we all want. So that's just kind of my bringing it home comparison. So I'm just going to talk about our great teams and how we look at things from the HTC and how we're able to take these wonderful tools we have, know the goals that we want to get to, and how everybody can work together to make that happen. So, we talk about comprehensive, and it's not just hemophilia care, it's bleeding disorder care. And a lot of times people say comp clinic, but we know that those of us who are part of the team, comp clinic is just one part of comprehensive care. It really is this year-long process or an ongoing process that requires a lot of people doing their specific roles to make it happen. But when we go to that comprehensive clinic evaluation, we do have certain goals, and what we're looking for is we're looking at the patient. It's designed to not be something where you're sick or you're bleeding or it's an emergency. It's kind of like your yearly physical at your HTC. So we're identifying, talking to the patient, identifying emerging issues, talking about any upcoming procedures or looking ahead at what might happen in the next year or two, really collecting discrete information. So collecting things in the same way for patients and doing it in a consistent manner that allows us to, over time, monitor how we're doing as we pull everybody's discrete data together and we can do some surveillance. And really identifying any care and knowledge gaps. This is a good time to have shared decision-making. And when we think about shared decision-making, if somebody's having an acute bleed and they're in pain, that's probably not the best time for this shared decision-making model. There's other priorities. But during the comp visit, you're really having some time to sit down and talk about it. And just think through what everybody's goals are. So the other thing is looking at everybody's comp clinic might look a little different, but we all have our same similarities. One of the exercises we went through is looking at who has to come to comp every year, who can maybe come every other year, every third year, and it just varies by the disease state, what therapies they're on, what some of their needs are, and really, but as we sat down and did that exercise and just kind of broke it down by diagnosis, it really makes it better for everybody to kind of talk through those goals. Looking at our services, who's going to see the patient, having those standardized health history questions based on specialty, and really trying to make it so unique that not everybody that goes in that room is saying to the patient, how's school going? Or, they do get sick of hearing that. So it's like, what are the questions I'm going to ask that are unique from the questions that somebody else is going to ask? And so how do we really make that patient feel that their time is worthy of being there and coming for those visits? We're going to do physical assessments based on your discipline or any kind of just other types of assessments. Laboratory monitoring is a big part of it, doing some surveillance there. And then having the whole team come together, because what we find is what they tell one person may be just a little different of how they told someone else, or they forgot to tell one person and the other person may have that information. So really coming back after comp as a team to talk through all of the concerns for the patient and develop a plan going forward. So when we talk about the hemophilia core team, if you look at like the definition and who are the probably every treatment center has this as the core team at least, and some people have more. So there's hematologists, we always have the nurse coordinator, the social worker, and the physical therapist. And really, but that's just part of the circle around this patient and family, because we're going to be communicating back to the primary care doctor who's in charge of that patient for the part of the year. Dental, going to the dentist is always a challenge with a bleeding disorder, not only for the patient to worry about, but for the dentist who's doing the procedure. So how are we looking in their mouths and seeing if they have any issues that we need to address? Joints and orthopedists, and hopefully over time, our need for orthopedists get a little smaller because joints are getting better, but that might be a person. And then genetics, looking at what your risks are. And now we're looking at it differently as well as not only what your risks of passing on the gene, but what is that gene, what specific risks for you does that gene, the gene may tell us, like, are you at high risk for developing an inhibitor? So we're just learning so much more about how important genetics are. And then the pharmacist, you know, is your dosing right? Is your, you know, do you have what you need at home? And, you know, this looks like a big team. All of these things need to be done, whether it's the 3 people if you're a small center, or more people if you're a bigger center. But really, these are all important parts for the patient and family. So what are the roles? These are just general roles of the HTC team. I mean, looking at the hematologist, the primary clinician, the APP, the NP, the person that is making the, talking to the patient and really thinking about the treatment plan specifically. What a bleeding disorder treatment. We have a lot to talk about now, as we have seen. It's not just, you know, you have a choice of 2 things. Now there's multiple things. How do you want to give it? Do you want it sub-Q? Do you want it IV? Do you want to give it once a week? You know, so there's just multiple things that we're talking about. Also, kind of finding the things that you can find on physical assessment, but knowing what can come next. What could be the next emerging thing, like bleeding episodes and joint disease, infectious disease, cardiovascular disease is becoming in the forefront for patients. Patients bleeding a lot, are they anemic? Are they having heavy menstrual bleeding? You know, need for routine procedures like colonoscopy. So, you know, what are our patients' risks and how do we safely do those? And then, you know, coming through with the nursing team, education, talking about treatment adherence barriers. You know, if somebody's not being adherent to their treatment, I'm sure it's not because they just wake up and say, I'm just not going to do it. There might be a barrier, and can we overcome that? You know, and looking at the rest, sometimes if you don't have a big multidisciplinary team to ask these other important things, a lot of times that falls on the nurse, whether it's research or doing maybe just some basic dental, getting dental information and that kind of thing. We look at our awesome social work team, looking at mental health, funding, care programs that are available for patients, and again, assessing and addressing their barriers to care. I mean, not every patient that we see has insurance. Not every patient that we see has reliable transportation, or reliable housing. So that is a very important piece. And then when we talk about our physical therapists monitoring joints, exercise activities, you know, our kids, our adults want to be active. That looks different for everybody, but how can they safely do it? It might be they need to have a little bit of joint support or something. And then, you know, also rehab. When we have patients that have orthopedic procedures, how do you get them back to where you want them to be? And being really the experts in that are on as part of your team. So the principles of ongoing care is it's a continuous process. Looking at, you know, a comprehensive visit, we say yearly, but if it's a patient maybe that you see every 2 years, you still need to see them for a regular visit in between. So that would just be a regular provider visit where you're waiting for the whole team to evaluate them, you know, for whatever their needs are. Because we can't predict when people are going to need factor at home or they're going to have an emergency. So hemostatic treatment for surgeries, dental, and discussions of new treatments once they're licensed. I feel like it's just, we're always talking about a new treatment and learning more about new treatments and sharing that with our patients. And, you know, when we talk about acute issues and how does the team work together to avoid, I mean, you don't want to have everybody from your team calling the patient on the same day. You don't want nobody calling the patient on the same day if there's a concern for them. So I'm just going to talk about a workflow for bleeding. This is for bleeding episodes, but these are things that we as the team think about to be able to have those outcomes we want. So, you know, the patient calls in with a bleed and really kind of like you're talking to them and what happened? And then their symptoms and their pain rating and what caused the bleed, because we want to know, was it spontaneous or was it traumatic? Because that makes a big, big difference. I mean, a spontaneous bleed may tell you that their therapy is not adequate, or it may be people that you identify that might benefit from from infusion training and having product at home if they don't have it. Where was the bleed? I mean, we're definitely interested in all bleeds, but thinking of joint bleeds and the emergence of a target joint, and a lot of us are tracking these kind of things. We have to report who's 4 bleeds or greater per year and those kind of things. And again, it's important to document these details in a very consistent way. So you can go back after the fact and compare patients and really look at, find the few patients that are having problems and really focusing on those. Did they infuse before they called? So that's something you want to know too. What's their current therapy? Hopefully you know because you're in the medical record, but do they have it at home? And is it not expired? And can they give it to themselves, or do we need to coordinate them at an outside facility? And then, timely communication back with them. It doesn't do you any good if you don't get back with them till the next day to give them recommendations on a bleed. So really just the first point of contact, collecting all of that really important information and really starting the process going. So, and really then part of it is telling the patient when you're going to call them back so they can, whether they're waiting on recommendations or they're already treating and now you're just going to call them the next day. So it doesn't end with nursing, because now we need our fabulous social work team does the patient need to come in to be infused, and do we need transportation? Do they have insurance coverage? Do we need to look at compassionate care programs? Can they attend school or work related to the bleed? Do they need FMLA? So there's all types of things that go way beyond just the bleed and just what we're treating it with. And then the psychosocial impact of that. And I think we all want our patients to feel well, feel confident, be comfortable, and really have, just feel like they can do what they want to do. We have our physical therapists that may come in. Does the patient need crutches or splints or other things to protect them? How do we get them back, if it's a joint or a muscle, to that baseline where they were before the bleed, and really working through them. Some of our physical therapists around the country have point-of-care ultrasound, so maybe they need to see that to tell, are they bleeding in the muscle or is it the joint? Or is the bleed resolving, or what they're looking at? So that's a valuable tool that allows us to look inside the joint and get a better idea of the bleed. And then what are the recommendations for post-bleed rehab? How do we get them back to where they need to be? So how does prophylactic treatment, so if you have a patient who's having surgery, does one of these products that they're on make a difference? How are you going to dose the patient for the actual procedure? And then what type of prophylaxis are you on? And all of those things now come into play. One of the things that I think we often face is the location of the procedure. So a patient's going to have a procedure. Is it going to be at your hospital where you can kind of control what happens, or is it going to be at an outside facility? If it's at an outside facility, can they really safely monitor that patient by, do they have product available? Do they know how to give it? Do they have lab that can help monitor? And then who at that outside facility is going to make that day-to-day medical decision-making? So when we look at our patients and all the people we interact with, primary care and OB, medications, comorbidities, immunizations, those are all things we're coordinating, dental visits, managing bleeds, managing procedures, emergency departments, subspecialists like surgical procedures, nutrition, screening for our patients that are anemic for iron deficiency, and how do we do that? Genetics, counseling and education, musculoskeletal needs, and rehab, and what do we do there? Moving over to the school and workplace, impact of absenteeism, appointments, how do they need accommodations, and can they participate in physical education? And from the workplace, insurance coverage, is it group coverage, are they self-funded, thinking through that. And then when we talk about how to have the home team do their job, it's infusion injection training, home prophylaxis products, do they have them, are they available, can they use them when they need them, and do they need prior authorization that might delay you getting product to the patient, and then tracking adherence. So when we talk about planning surgeries at an outside thing. A lot of us have a surgery letter that we would use that would identify really kind of what your plan's gonna be, discharge instructions, communicating to everyone who needs it, making sure they have that letter's accessible and they can see that. And then discharge planning, I think that's the big thing. Who's coordinating it? You know, a lot of hospitals have discharge planners that will know nothing about what your patient needs. And once they go home, it's all up to you at that point. So looking at the products that they need and how do they get that product and continue that treatment plan, and then monitoring them afterwards. We are now worrying a little more about inhibitor development now that we have these people that aren't getting factor on a regular basis. So there's some other things about tracking, making sure that the treatment plan was completed. So if you have a patient who we always call them like 2 weeks after the procedure because we want to know, did they have bleeding? Did our plan work? If not, why didn't it work? Is it that they didn't take it? Is it that it was a bad plan and we shouldn't use that plan anymore? Was it something that no one can prevent? And really capturing all that information in a consistent manner. And it allows you to look quality over time. You know, are our treatment plans working? Because can we use them again for the next patient? So this is really looking at patient-centered care for hemophilia and really all bleeding disorders. You know, we're looking at other disciplines to help us, not just the medical teams. We're building relationships with the family by offering the support that they need. We're viewing our patients as people, knowing that they're unique and everyone has different challenges and attributes that we want to take advantage of, and then managing the expectations. So I'm going to turn it back over to Stacy and individualized hemophilia care.
Well, thank you both for excellent presentations. I hope everyone enjoyed those. Let's give you guys both actually a round of applause. That was really excellent. So where are we now? We've talked about some ways of assessing outcomes, bleed outcomes, musculoskeletal outcomes, patient-reported outcomes. We've taken a look at some of the old and newer therapies available. We've taken a look at team dynamics, communication, logistics, tracking. Now we're going to try to put it all together in a few cases. So hopefully you guys have come up with some great questions. Don't forget to be entering your questions into the Connect platform. These cases also fair game for questions. So if you have additional things to bring up about these, we can do all of that at the end as well. So let's start with Samir. Samir is an infant, just 8 months old, has a diagnosis of severe hemophilia A. So he's an infant that did not have any family history of hemophilia and was actually not even identified in the neonatal period. He was referred by his primary care physician after being diagnosed due to coagulation screening because the parents noted as he started to reach more motor milestones, he seemed like he was bruising a lot more easily than they expected. He spends a lot of time at daycare with other babies, but also trying to follow along with some of the other toddlers, and parents are working full time. So from the beginning, right, brand new diagnosis, he's on an on-demand bleed treatment regimen right now. He fortunately has not had any prior factor VIII exposures because we didn't know he had hemophilia, and he fortunately hasn't had any bleeding. And you can see that it is truly severe hemophilia with the most common pathogenic variant of an intron 22 inversion. So parents are coming for their first consultation visit with you. They've heard from the pediatrician, yikes, these coagulation studies are desperately abnormal. It looks like severe hemophilia. We want you to go see a specialist. So now they're coming to establish care, and they want to learn more about hemophilia, but from the first time, right? No family history, no exposure. And how are they going to care for this infant at this point? So question for all of you as we kick off our discussion. What would be your primary goal to achieve with Samir's parents at this first visit? Education about recognizing bleeds and when to seek emergency care, creation of a treatment plan for home, for daycare, for travel, selection and initiation of a prophylaxis regimen, awareness of long-term health considerations, inhibitor development, activity restrictions, joint damage, or would you prioritize some other goal that isn't listed here? a bit of a majority focusing on recognition of bleeds and when to seek emergency care, but sort of a nice distribution. Folks also feeling that creating a treatment plan for home daycare, travel, very important, prophylaxis. So all of them are important. Maybe we'll start at the end. Jennifer, from your perspective, seeing this family for the first time, how would you prioritize some of these things and how would your conversation kick off?
Yeah, I mean, I think it's hard because you want to give them all that information, but they can't absorb it. And especially if it's a family that has no idea about hemophilia and it's really a shock to them, how much are you really going to do? So I think I would agree with the one thing you have to make sure they know is when to call you and where to go. I mean, you have to start talking about where you're going to go. Hopefully they live close enough that they can come to the center, because emergency room is just not the place for a young baby with an unsure family. And so, you know, I think that one of the important things to put in place is a series of communications, knowing that they're not going to absorb everything in that first one. So just making sure you got that covered, and then maybe follow up the next day and start getting some of those pieces in place, like medical alert bracelet and all of those things that you're going to want the patient to have over time to keep them ready.
Completely agree. Miguel, how about from your perspective?
I think once you have that diagnosis, the most important thing is education, you know, to the family, and again, in regards to the entire disease, right? What are the risks for that baby? And how are you going to prevent bleeds is the other part. You know, what if you're going to put them on prophylaxis, what are you going to recommend, and what are the options, you know, at this point for him? So I think education is critical, because that's what's going to, you know, give them the information to prevent bleeds or have, you know, some big complications down the road.
Right, and I think 1 and 2, of course, go hand in hand. So you have to be able to recognize a bleed. You have to know when to seek emergency care. But as you mentioned, Jennifer, both you and Miguel, you need a plan in place, right? Because maybe you're home, maybe you're traveling to grandma's, maybe you're traveling for other things that have been planned. So you need a recognition, and this is what we're going to do about it. And it is such an overwhelming first meeting, right? You're getting through hemophilia and factor VIII, and this is even the diagnosis, let alone when the rubber hits the road of these types of things. So being able to pair that with some written educational materials, making sure they know where to find the information if they have some type of patient portal, whether it's a Epic MyChart or a Power Chart or what have you, and giving them written things that they can take with them. Do both of you leverage like travel letters, written educational materials, and things like this?
Yeah, and I think if they're not ready to hear everything, you know, just really setting that plan. You know, we're going to be talking about treatment, and we'll get you all set, you know, don't worry. I mean, that's kind of what you want to talk about, is we're here for you. Yeah.
But at the same time, we all recognize that prophylaxis is really important. An early initiation of prophylaxis is really important. And this has changed a lot in the last 10 to 15 years. Where, as you heard, mid-90s, we're recruiting for the joint outcome study. We're looking at, well, let's see if we can start prophylaxis sometime before 30 months is our early initiation. And everyone else, we're going to start prophylaxis by 6 years. I'm curious, for your newer hemophilia patients, what age are you typically starting prophylaxis?
I can answer that. I mean, it depends. For factor VIII, we're starting right away, as soon as we can.
Yep. So right with diagnosis, whether it's newborn, 8 months old, 6 months old, may not be the injection during that first visit.
No, you kind of wait,
quickly
but you want to open it
thereafter.
up for that conversation.
And how does that contrast from your hemophilia B patients?
It's different.
It's different.
Yeah.
Because we're still kind of following a bit of an older model, if you will, in that regard. Is that true for you as well?
Yeah, because I mean, that baby is going to bleed sooner or later, you know, with a severe hemophilia. So the issue is when to start and how to recognize it, especially for, you know, for the parents.
And so once we agree that we are going to start, then of course the question becomes, what are we going to start?
Yeah.
So Miguel, what options, if any, do you present to the parents? Is this a shared decision-making? Is this a strong Dr. Escobar recommendation? How do you approach that?
I think we have to start, you know, with all the options are available where we have, you know, the recombinant standard half-life factor VIII that we know we were being using for years and years, or we can go to a, you know, non-replacement therapy, something like emicizumab, or one of the rebalancing agents as well if they're approved. But you have to, you know, put on the table all the options for the family and explain the pros and cons of each one of them, you know, because I think this baby is at risk of having, you know, we got to prevent a head bleed. Absolutely. Or any type of joint bleed. I think will be very, very helpful to do at this point.
Jennifer, in your experiences, you've been presenting new families with the kind of options. So we can maybe chunk it into factor concentrate options, perhaps, or non-factor concentrate options. What is your sense of common preference or different elements that new parents tend to be weighing and how they make that decision?
Yeah. I mean, I think especially for hemophilia B, right now the only products that are available for that age group are IV. So how can you successfully complete the IV therapy? And that kind of ends up being kind of a decider for that group. You know, so it's looking at factor VIII where we do have a sub-Q option, factor IX we don't, so we have to figure out how to start successful infusion, and a lot of times it's putting a port in and doing it that way.
But I will share, you know, many of my new families really like the subcutaneous option. It's easiest to learn how to administer if you don't already have IV skills. It provides protection. They are often curious and say, but what happens if little Johnny wants to do this in the future? What happens if we want to do this? Is this our moment to decide? And then we go on. And so I think reinforcing, right, that this is something we revisit from time to time. Here are your options. What are your goals? What are you doing now? And so you're not locked into any one specific therapy. It's sort of an iterative process over time. So I guess here, you know, safety first. Always a good first principles of medicine. So emergency care plans, bleed management 101, but it will be important to really revisit the big topics, overall family education, thinking about treatment decision-making, and helping to empower the parents to say, this will be shared decision-making. So it will be important for you to learn to participate in how we think about these decisions. And then, of course, you know, letting them decide with, you know, appropriate guidance, input, walking through the process. Or Jennifer, if you had any additional.
Yeah, and I wanted to just kind of share, if you're not familiar with it, the World Federation of Hemophilia has a very nice shared decision-making module. There's information on there for providers. I mean, I think if you said shared decision-making to a patient, they probably wouldn't know what you were really talking about. But they can go on. It helps them think through things and put their preferences down, and it's really to prepare them to come back and talk to you and have it laid out. So it's a really nice tool. Tomorrow in the nursing fair, I'm going to just show some pictures of what it looks like once you go on that website. But it really does answer a lot of questions, and it's a good visual for the family. It has them rate different things, so I'm just putting in a plug for that. And I think that when we talk about it's person-centered, I think everybody who's a provider, anybody on the care team knows how to put the patient first and really taking the time to talk to them. So these are some things that are listed, but like I said, I'm plugging that shared decision-making tool, so I would encourage everyone to go to the website and look at that.
Completely agree. I think that tool makes it very approachable. And then families, patients, individuals can do it on their own time in anticipation of the comp visit. I think, as you nicely said, it walks you right through a lot of prompts and questions, lets you print out a summary at the end, so you can use that to help your discussion with your providers when you get to the clinic visit, so you don't even have to remember everything you are going through, because I'm sure all of us, whether providers, patients, caregivers, you get into those clinic visits, right? And it's sort of like rapid fire, different things going on. Maybe you're steaming in from work or school or practice, and your mind's going a million miles a minute about other things. So I think this helps consolidate the information in advance and really help people be there and ready to be present. So Dr. Escobar, I think you had Caleb, is that true?
Yeah. So Caleb is a 45-year-old with severe factor IX deficiency and had no history of inhibitors. This patient, growing up, received plasma-derived factor IX to treatment of the acute bleeds. He started prophylaxis actually at the age of 25 when he first got to the US in one of the HCCs. Initially, he started with standard half-life factor IX, 40 units per kilo once a week, but unfortunately, he was having, frequent bleeds, or at least an average of 4 bleeds into the joints a year. He has damage of the joints because of the bleeding when he was young in the lower extremities, both knees, and I think he has, issues with one of his ankles as well. And you can see there, he definitely has joint disease already. At least in the X-rays, we can see it on the physical exam as well. So the issue is, he likes to play tennis and he wants to continue playing tennis. Is that an option, or how can we improve his bleeding phenotype on this individual?
So we're going to put that question to all of you. So given Caleb's goals, what prophylactic option would be your top recommendation for Caleb to consider? Going back to standard half-life for recombinant 9 twice weekly, thinking about a high sustained activity or extended half-life factor 9, switching to a rebalancing agent, or confirm eligibility and discuss benefits, risk, and think about gene therapy. Strong sentiments for gene therapy, but a nice mix of a lot of therapy ideas. So what do you think, Dr. Escobar? Which did you think was the best prophylaxis strategy?
For patients with hemophilia today, I think gene therapy is a very good option, and unfortunately it's only approved for severes, but I think even milds and moderates could potentially receive gene therapy, and, I think that will definitely improve their management.
And as we think about overall health, liver health,
right.
Sort of the risk balances of gene therapy, if ultimately Caleb says, well, that's interesting, but I don't know that I'm quite ready to embark on gene therapy, tell me a little bit more about these rebalancing agents. How would you approach the conversation about the available rebalancing agents with him?
If he has a liver that is very healthy, so I think that any of the rebalancing agents will be, something like martezumab could be a good option for him, right? Once a week. He seemed to be pretty active, so I think that will help him prevent, some of the bleeding. But an extended half-life factor 9 could be also a good option for him. He can even use it every 2 weeks. I have patients with hemophilia B that takes it one dose every 20 days. And I think, that will be also ideal, knowing that, by using factor, there's always that risk of developing an inhibitor, but, that's something that we will not know until we try. But I think gene therapy is a really good option for this patient.
So Jennifer, between gene therapy, rebalancing, how would you help counsel him?
I think it would depend on what his goals are, and does he want to risk gene therapy at this point or wait until the technology's a little better, where a rebalancing agent might buy him a little more time? Does his venous access, because if all he learns is sub-Q, he'll never know how to treat a bleed. So as long as he's capable of infusion therapy, would that be the first step to that? So I think it could be any of them.
He's a really great patient in that regard, right? The whole kind of the treatment spectrum is his oyster, and he really gets to pick and choose based on his real preferences. Excellent. All right, I think you have Alex.
Yeah, so this is mine. Alex was diagnosed at a year of age, maternal grandfather with hemophilia, so they knew he was at risk. But the challenge with Alex that kind of has a shadow over a lot of the decision making is that he's needle phobic, and his mom's his primary infuser. So he was on episodic treatment. He's a moderate. until 14 years of age, and then he started prophylaxis with factor VIII until he was 21. He played baseball. He's a very active kid. That's kind of what prompted him to start prophylaxis. He's on elite travel teams. You know, we have, I think a lot of us have these very serious athletes that then receive college scholarships. So now he's in this very competitive environment. But the college is 3 hours away. Now remember, point 2, he's needle phobic. So he had a lot of sports-induced trauma during college. You know, he brought product from home, but every time he had to have an infusion, he had to coordinate it somewhere. And so what happens at 21 years of age, his senior year, he switched to emicizumab to eliminate the need for IV therapy and reduce the frequency, but he still was needle phobic for sub-Q injections as well. So his mom would go to campus every 4 weeks to administer his emicizumab. But now so it worked out, the family made it work, but now he's graduating and relocating to a new state, and he's employed full-time. He's no longer in competitive sports, so are his bleeding risks as high, but he's still working out regularly. Still does not self-administer his emicizumab due to this overwhelming needle anxiety. And it is a thing. I mean, some of us think that, oh, come on, but it really does impact the care of some of our patients. So with his new job, the new HTC's an hour away from his apartment. You know, prophylactic requires if he would go on any kind of prophy, it would be quite a distance for him to go. Taking half a day from work was a big deal for him for prophylaxis. And so the goal of the visit is just to kind of talk through and discuss what could happen and what could he potentially use. So what might some options be for this patient? You know, continue his emicizumab, you know, at the HTC. It means he's going to have to go there to get it done, which is, you know, missing some time from work. Learn to self-inject the Emmy at home or at work. Switch to a high sustained activity factor replacement, really, again, administered at the HTC. Switch to a rebalancing agent, but we still have to administer it at the HTC. And, you know, pursue enrollment in gene therapy. He's a factor VIII, so, you know, and then the discussion includes explanations of all the options that require continued absence from work unless he learns to self-administer. So this is just lots of dilemmas on this patient. There's lots of options for this patient, but he's still very limited because of this needle phobia and now not living close to mom and really not living close to an HTC either. So what would you talk to him about and recommend next steps for Alex at this point in life? Would you really start pushing to self-administer the emicizumab? Would you say trying that high sustained activity factor VIII concentrate? Would you suggest some of the rebalancing agents, either the anti-TFPI ones or the siRNA rebalancing? Or would you explore gene therapy from a clinical trial? And at this point, factor VIII's not available.
Maybe 6, encourage mom to relocate.
Yeah, right. I said a girlfriend, right?
Significant other.
Is there a nursing school close by or a, you know? Okay, 43 of us are going to say, come on, dude, you could do it.
He needs to buy an electric car. You know.
An electric car, right?
You know, to make it cheap.
So we have a little mix of the other options for him. And like I said, he has options, but they all start with a needle, whether it's a little needle or a bigger needle. And then explore gene therapy clinical. Is there anything in clinical trials? So he is a true patient, and he's kind of a dilemma. So.
I guess one option will be to maybe start with fitusiran every few months and then switch.
Could be, yeah. And mom could visit him every couple months.
Every few months, yeah.
Do laundry, do the whole thing.
Yeah, right. clean his apartment. Yeah, that's a great, that
100%.
wasn't an option. We were just saying, deal with it.
So therapy, it just because it wasn't a mic, right, therapy, do we need additional psychosocial support? Some,
Yeah,
work with cognitive behavioral therapies, things like
Yeah,
this. Immersion.
yeah.
I totally agree.
So learning to administer, is it essential for every adult with hemophilia? And I think it varies by what your family support is. I mean, of course, we want everybody to learn, but we still have those who either don't want to learn, can't learn, or something standing in the way. So, I mean, I think with, and it's really going back, I always think about like our mild patients too that don't bleed that often. And, you know, what's the approach to teaching them to infuse and be independent if it may be a little while before they need to use it again? And I don't know about
Like it's
what
not
you're
essential,
saying.
but boy, it makes everything a lot more convenient.
It does.
With the current prophylactic therapies. And this is something I think we've all heard from our parents who went from treating with regular factor VIII concentrate and probably had ports in place, and then had the miracle of the factor VIII mimetics, subcutaneous, ports come out, we are free, but then the first bleed, and now they're much more reliant on the institutions again. Now we have to find a nurse to get here in short order, or we have to go to the day infusion program, or now we have to go to the emergency room. We've lost our autonomy and our ability to just treat, call, and move on. But when you're bleeding so infrequently, whether you're on a really good prophylactic agent or just mild hemophilia, how do you have an opportunity to get those skills, maintain those skills? Challenge.
Yep. One of the things that with high sustained activity is, you know, you don't have to infuse right before the procedure. Now you can do it the day before and still be okay for those procedures. So it's just a different way of thinking about it. Dr. Escobar, would you say that that's kind of how your practice is going right now?
I think so, yeah.
Yeah. And then just really counseling patients with hemophilia A who are good candidates. You know, is this the time? For some patients it may be, and not only the time, but having the time to take it seriously and have that good, intense follow-up in the beginning. It's not just a one and done thing, so.
Excellent discussion. All right, so we have a few parting takeaways, but we do have some great questions. So I'm going to ask one more time to see if we've changed any minds. What non-ABR outcome measure might you prioritize more highly after this session? Factor levels and inhibitor assays, PK profiling, clinical joint health assessments, musculoskeletal imaging, physical function assessments, psychosocial or quality of life self-assessments. Fascinating, excellent. So I think really exciting to see what I see as sort of an extension of kind of the shared decision making in a sense. Really taking into consideration psychosocial considerations, quality of life assessments. How are we doing from your perspective, patients? That's really terrific. We've got a few great questions, so keep them coming through Connect, both online as well as all of you in the room. So Jennifer, you showed a really excellent diagram of sort of the core Hemophilia Treatment Center team members, but also highlighted that it takes a village, and we have a lot of other specialists that we refer to regularly, some slightly less regularly, either online or maybe excitingly even here, we have an audiologist. And so the very reasonable question about, of all of our hemophilia therapies, any concerns for ototoxicity or regular need for an audiologist, and kind of how we think about those things. Miguel, Jen. So fortunately, right, I think unlike our cancer patients, we do quite well with minimal toxicity.
I've never even thought of that.
So no ototoxicity, but we love to expand our team. So I'm sure we could find some reason to help include you. So, but thank you for joining. I so appreciate that. Subcutaneous options, primarily for 12 plus. When we're thinking about the rebalancing agents, certainly for one of the TFPI inhibitors, the marstacimab, we're now 6 plus. For the factor VIII mimetic emicizumab, we're birth to the end. Any chance we know anything about the therapies being expanded to the 0 to 6 age group?
Yeah.
And I think they're working on that, trying to.
I think so. So we don't have any insider knowledge that we can share at this time, but I do think, right, that ongoing expansion to the younger age groups will be really important, I think, particularly for those patients as we address the hemophilia B patients, right, where we're now still delaying prophylaxis either till first severe bleed or till reasonable IV access, kind of that 9, 12 plus month age group, and starting prophy earlier and having a subcutaneous option would be really terrific.
And I think when you get into that younger age group, maybe you're less worried about as many comorbidities. Very few babies have hypertension and type 1 diabetes and all of that. So,
The toddlers, you can't slow them down.
Yeah.
So the risk of blood clotting seems quite low in that regard. Any data on subcutaneous therapies and how they compare to clotting factor concentrates for joint bleed protection? How do you counsel patients when they're thinking about prophylaxis in terms of joint health, clotting factor concentrates versus non-factor therapies? What do you think, Dr. Escobar?
I mean, I think that if we look at for example, the HEAVEN studies, we saw patients who had breakthrough bleeding, and we still have patients on emicizumab that bleed, have breakthrough bleeding, and they have to administer, something for the acute bleed. And the data, even though it shows a low rate of bleeds, still, patients bleeding, even though it's a clinical trial.
Yep.
So I think that you have to be very open with the family and explain, that there's always that chance. They're not 100% protected.
Yep, I agree.
Yeah, and I think it's those joints that are just bad to begin with that are a little more sensitive to not very much movement that, some of these agents might not protect totally against. I mean, it improves everything, but so we've had some patients who weren't getting as much results as they wanted from a sub-Q therapy, and then they went back to factor. And those are patients who just were able to infuse anyways. So, and some people just felt better about being on an infusion because that's what they know.
I think this is a great example of where it's important to look at the clinical trial data, registry data, but we really have to individualize. So when you look across the clinical trials and those who were recruited, essentially all that I can think of the non-factor therapies showed improvement in joint bleed rates and improvement in target joints for that population. But again, we kind of go back to who is that population and the generations of hemophilia, right? So to your point, bad joints are not going to result in fully corrected joints on the backside. But as we move down to the younger individuals who start with more pristine joints, we may have a better chance at maintaining their joint health over time. But we have to learn more, right? And this is why getting beyond just even the physical exams with the HGHS, thinking about even in the pediatric population, ultrasound, potentially MRI, how are we doing? Other bone markers, how are we doing with the prophylaxis, even with microbleeds or other types of joint damage that may remain subclinical throughout the pediatric range, but may still result in earlier onset of arthritis or earlier onset of joint disease down the road. And that we still have to learn more about. I think we just need more years with these therapies for sure. Thank you for all of your questions. I do want to point out some additional really helpful educational resources for novel hemophilia therapies. So through our MASEC guidelines, there's some great recommendations for the use and management of anti-TFPI pathway inhibitors, as well as antithrombin knockdown. And ISTH Academy also has some really helpful educational resources, new class, new conversations, understanding and explaining anti-TFPI agents, as well as updates in factor VIII mimetics, advancing hemophilia today and tomorrow. So do look out for those. I think you'll find them quite excellent resources. And then if you haven't had quite enough, Jennifer and myself are going to do a recap in a few weeks. So join us September 10th. It's going to be fast and furious. You only get us for about 15 minutes, but we're really looking forward to speaking to you again about individualizing care in hemophilia. Social media event, my favorite. So that should be great. And we finished up some questions and answers. Thank you all for joining us tonight. We hope you had a really wonderful time. I almost forgot. Oops, sorry. Pause, because we want everyone to get the CME, continuing scan, fill out surveys, get your credit, and then go and continue to enjoy BDC. Thanks so much.